Every 14 minutes, someone in the United States dies from complications that began with something most people never discuss at dinner parties, something doctors whisper about in emergency rooms, something that literally everyone does but almost no one understands is slowly becoming one of the most dangerous hidden health crises of modern life. The condition starts silently, it progresses invisibly, and by the time most people realize something is catastrophically wrong, the damage has already moved from uncomfortable to potentially fatal. Dr. Liana Wen has stood in emergency departments at 3 in the morning, watching the color drain from a patient's face as monitors begin alarming, blood pressure dropping, heart rate spiking, knowing that what brought this person to the edge of death started days earlier with a simple decision about what to eat for lunch. The medical term is fecal impaction. The common description is constipation, but neither phrase captures the genuine medical emergency that unfolds when hardened stool becomes lodged in the rectum, creating a cascade of complications that can rupture intestinal walls, trigger systemic infections, cause heart attacks, and yes, kill otherwise healthy people. Right now, as these words are being spoken, approximately 38 million Americans are dealing with chronic constipation. Among them, nearly 2 million have progressed to impaction without realizing it. Their digestive systems are backing up like plumbing in an old building, pressure building, toxins accumulating, and the 7 specific foods that Dr. Liana will reveal in the next 30 minutes are the primary culprits making everything worse. These are not obscure ingredients. These are items sitting in pantries and refrigerators right now, foods that advertising has convinced millions are healthy, normal, even beneficial, while they systematically transform the digestive tract into a ticking time bomb. The question is not whether this information applies to someone watching. Statistics make that certain. The question is whether they will recognize the warning signs in time and which of the 7 foods they are consuming right now, today, this very week, that are silently contributing to a condition that sends 425,000 Americans to emergency departments every single year. Problem amplification, 18 to 22%. Understanding why stool stuck in the rectum can kill requires understanding what happens in the body when the digestive system stops moving waste efficiently. The human colon, that final segment of the digestive tract measuring approximately 5 feet in length, has one primary job: extract water and minerals from food waste, compact what remains, and move it toward elimination. When this process works correctly, it happens so automatically that most people never consider the elegant coordination of muscular contractions, neural signals, bacterial colonies, and chemical messengers required to make it function. But when this system breaks down, when stool begins to harden and slow, when the rectum becomes a storage facility rather than a transit point, the consequences ripple outward in ways that most people never connect to their original source. Dr. Liana has reviewed hundreds of cases where patients presented to emergency departments with symptoms that seemed completely unrelated to digestion: chest pain that mimicked heart attacks, confusion that suggested stroke, abdominal pain so severe it was mistaken for appendicitis, urinary retention requiring catheterization, respiratory distress that looked like pulmonary embolism. And in every case, the root cause was fecal impaction, stool packed so tightly in the rectum that it triggered a domino effect of medical crises. The first danger comes from direct mechanical pressure. When hardened stool accumulates in the rectum, it does not simply sit there passively. It presses against the walls of the intestine with increasing force. The rectum, unlike other parts of the digestive tract, has limited capacity to expand. It was designed to hold stool temporarily, not permanently. When that temporary holding becomes permanent blockage, the pressure begins to compromise blood flow to the intestinal wall. Tissue that does not receive adequate blood supply begins to die. This process, called ischemia, can happen gradually over days or suddenly over hours. Either way, the result is the same. The intestinal wall weakens, thins, and eventually perforates. A perforated bowel is one of the most dangerous surgical emergencies in medicine. When the intestinal wall ruptures, bacteria-laden stool spills directly into the abdominal cavity. The human colon contains approximately 100 trillion bacteria. many of them harmless when contained within the digestive tract, but catastrophically dangerous when released into the sterile environment of the abdomen. Within hours, sometimes minutes, the spillage triggers peritonitis, a whole body inflammatory response. Blood pressure drops, organs begin to fail, and mortality rates, even with aggressive surgical intervention and antibiotics, hover around 30%. Dr. Liana remembers a 52-year-old accountant who arrived at the emergency department complaining of abdominal pain that had started 3 days earlier. He described it as pressure, discomfort, nothing terrible. He had taken over-the-counter pain medication. He assumed it was something he ate. But by the time he walked through the emergency department doors, his abdomen was rigid, his skin was gray, and his blood pressure was barely maintaining consciousness. Emergency surgery revealed a perforation in his rectum the size of a dime, fecal matter throughout his abdominal cavity, and sepsis that required 3 weeks in intensive care and 4 additional surgeries to control. The cause? 7 days without a bowel movement and a diet dominated by 3 of the foods Dr. Liana will identify shortly. But perforation is not the only lethal complication. The second major danger comes from what medical professionals call overflow diarrhea, a term that confuses patients because it sounds like the opposite of constipation, but is actually one of its most dangerous manifestations. When hardened stool completely blocks the rectum, liquid waste from higher in the digestive tract has nowhere to go. It cannot pass the blockage, so it begins to seep around it, leaking out in small amounts that patients mistake for diarrhea. They take anti-diarrheal medications, which make the underlying impaction worse. Meanwhile, the blockage remains, the pressure increases, and the risk of perforation climbs. Researchers at the Mayo Clinic conducted a longitudinal analysis following 7,300 adults over 65 years of age for a period of 12 years using comprehensive medical record review and standardized assessment protocols, and they discovered that participants with chronic constipation had a 41% increased risk of cardiovascular events, including heart attack and stroke, compared to those with regular bowel movements, even after controlling for diet, exercise, and other cardiovascular risk factors. The mechanism behind this correlation reveals how intimately connected gut function is to whole body health. When stool remains in the colon too long, bacteria have extended time to ferment undigested material. This fermentation produces gases and metabolic byproducts, some of which enter the bloodstream through the intestinal wall. Among these byproducts are compounds that trigger systemic inflammation, the same low-grade inflammatory state associated with atherosclerosis, the hardening of arteries that leads to heart attack and stroke. Additionally, straining during bowel movements, which becomes inevitable with chronic constipation, dramatically increases blood pressure in the moment of straining. For someone with underlying cardiovascular disease, this sudden spike can rupture vulnerable plaques in coronary arteries or trigger arrhythmias that cascade into cardiac arrest. Dr. Liana has witnessed this exact scenario more times than she wishes to count. A patient in their 60s or 70s, struggling in the bathroom, bearing down with maximum effort against stool that will not move, blood pressure spiking from normal to dangerously high in seconds, and then the chest pain starts. Sometimes it is angina, a warning. Sometimes it is a full myocardial infarction, heart muscle dying as blocked arteries fail to supply the oxygen needed for the intense cardiovascular demand of straining. The death certificate will list heart attack as the cause. The underlying trigger was fecal impaction. The third lethal pathway involves urinary retention and kidney damage. The rectum sits directly behind the bladder in the pelvic cavity. When the rectum becomes distended with impacted stool, it presses against the bladder and urethra, physically blocking the flow of urine. Patients suddenly cannot empty their bladders completely. Urine backs up into the kidneys. Hydronephrosis develops, the kidneys swelling with trapped urine, pressure damaging the delicate filtration structures. If the blockage persists, acute kidney injury follows, waste products accumulating in the bloodstream, electrolytes becoming dangerously imbalanced, and the cascade toward multi-organ failure beginning. Then there is the psychological and neurological dimension that most people never consider, The gut contains more than 500 million neurons, so many that neuroscientists refer to it as the second brain. This enteric nervous system communicates constantly with the brain through the vagus nerve, a major neural highway carrying signals in both directions. When the gut is chronically distressed, when stool sits fermenting and pressure builds in the rectum, these signals flood the brain with information that manifests as anxiety, depression, brain fog, and cognitive dysfunction. Research teams at Johns Hopkins University examined 2,800 participants across a 4-year period using standardized depression inventories and colonoscopy-confirmed constipation diagnosis. And their findings demonstrated that individuals with chronic constipation were 3.2 times more likely to develop clinical depression compared to controls, suggesting a bidirectional relationship where gut dysfunction impacts mental health, and mental health impacts gut function. But perhaps the most insidious danger is that fecal impaction rarely announces itself with obvious symptoms until it has progressed to dangerous levels. Early constipation feels like minor inconvenience. A day without a bowel movement becomes 2, then 3. Discomfort is mild. Life continues. By day 5 or 6, there is bloating, decreased appetite, a sense of fullness. Still, many people normalize these feelings, assuming they will pass. By the time pain becomes severe, by the time overflow diarrhea starts, by the time urinary retention or confusion or chest pain develops, the impaction has often become so severe that manual disimpaction or even surgery is required. Dr. Liana emphasizes that the medical community bears some responsibility for this lack of awareness. Bowel function remains one of the last taboo topics in healthcare. Patients feel embarrassed to mention changes in their bowel habits. Physicians often fail to ask about them during routine visits. And the result is that millions of people suffer silently with a progressive condition that has clear warning signs and highly effective interventions if caught early. The tragedy is that most fecal impactions are entirely preventable. They do not result from mysterious genetic disorders or unavoidable aging processes. They result from specific, identifiable dietary choices combined with lifestyle factors. And among all the dietary contributors, 7 foods stand out as the primary culprits. Foods so common that most people consume at least 3 of them weekly without any awareness of what they are doing to their digestive systems. Solution introduction, 12 to 16%. The path out of this crisis is not complicated, but it does require information that the food industry has spent billions of dollars obscuring. Because the 7 foods that most commonly contribute to fecal impaction and chronic constipation are also among the most profitable products in the American food supply. They are shelf-stable, highly processed, heavily marketed, and engineered to be consumed frequently. Their elimination from the diet threatens revenue streams worth hundreds of billions of dollars annually, which explains why the evidence about their impact on digestive health remains largely hidden from public awareness, despite being well established in gastroenterological literature. Dr. Liana wants to be absolutely clear about what the next section will deliver. This is not a list of foods to reduce or moderate. This is not about portion control or occasional indulgence. The 7 foods that will be identified in the mechanistic deep dive are foods that must be completely eliminated from regular consumption for anyone who values long-term digestive health and wants to avoid the very real risk of fecal impaction and its potentially fatal complications. The evidence is not ambiguous, the mechanism is not theoretical, and the clinical outcomes are not subtle. But before revealing what these foods are, it is essential to understand why they are so damaging. The human digestive system evolved over millions of years in an environment completely different from the modern food landscape. Ancestral diets consisted primarily of fibrous plants, occasional lean proteins, seasonal fruits, and very limited quantities of concentrated starches or sugars. The digestive tract adapted to process high volumes of fiber, materials that resist complete breakdown and provide the bulk necessary to stimulate peristalsis, those wave-like muscular contractions that move waste through the intestines. Modern processed foods represent a radical departure from this evolutionary template. They are designed for maximum palatability, shelf stability, and profit margin, not for digestive health. They concentrate calories while removing fiber. They add binding agents and preservatives that change how food moves through the gut. They create textures and flavors that override natural satiety signals, encouraging overconsumption. And they do all of this while being marketed as convenient, normal, even healthy components of everyday eating. The 7 foods Dr. Liana will identify shortly all share common characteristics. They are low in fiber or completely fiber-free. They contain binding compounds that absorb water in the digestive tract. They slow intestinal transit time, meaning food takes longer to move from mouth to elimination. They alter the bacterial composition of the gut microbiome in ways that reduce production of short-chain fatty acids, compounds essential for healthy colon function. And they create metabolic conditions that decrease the natural muscular activity of the intestines. When these foods dominate a diet, when they are consumed daily or multiple times daily, the digestive system gradually slows down. Bowel movements become less frequent. Stool becomes harder and drier. The urge to defecate weakens as the rectum adapts to constant fullness, and the stage is set for impaction. The solution is not a pharmaceutical one, though medications certainly have their place in acute management. The solution is dietary elimination combined with strategic addition of foods that actively promote healthy bowel function, and the evidence supporting this approach is overwhelming. Multiple randomized controlled trials have demonstrated that increasing dietary fiber while eliminating binding, low-fiber foods can restore normal bowel function in 70 to 80% of people with chronic constipation within 2 to 4 weeks. No medications required, no procedures needed, simply removing what damages and adding what heals. Dr. Liana has guided hundreds of patients through this process. The pattern is remarkably consistent. Week 1 involves education and preparation, identifying which of the 7 foods are currently in the diet and planning replacements. Week 2 is elimination and adjustment, navigating cravings and social situations, while the body begins to respond to increased fiber and hydration. Week 3 typically brings the first significant improvements, bowel movements becoming more regular, stool consistency normalizing, bloating decreasing. By week 4, most people report that digestive function feels better than it has in years. Energy improves, mental clarity returns, and the fear of impaction recedes. But this transformation requires knowing what to eliminate. It requires specificity, and it requires understanding not just the names of these foods, but the mechanisms by which they damage digestive function. Because that understanding is what transforms intellectual knowledge into sustained behavioral change. Mechanistic deep dive, 38 to 42%. The first food that must be eliminated is processed cheese, and this includes cheese slices, cheese spreads, cheese sauces, and any cheese product that lists sodium phosphate, sodium citrate, or similar emulsifiers in the ingredients. The reason processed cheese is so particularly damaging to bowel function relates to both what it contains and what it lacks. Natural cheese, while low in fiber, at least contains fat and protein in ratios that allow it to move through the digestive system relatively efficiently. Processed cheese, however, contains emulsifying salts, specifically designed to bind water and create a stable, smooth texture that does not separate or spoil quickly. When processed cheese enters the digestive tract, these emulsifiers continue doing exactly what they were designed to do. They bind water. The colon's primary function in the final stages of digestion is to extract water from waste material, compacting it for elimination. But when emulsifiers from processed cheese are present, they compete for available water, pulling moisture away from other components of stool and into chemical complexes that make the entire mass drier, harder, and more difficult to move. Additionally, processed cheese typically contains 2 to 3 times the sodium content of natural cheese. This excess sodium further draws water out of stool through osmotic pressure, exacerbating the drying effect. Dr. Liana has reviewed colonoscopy reports and dietary logs from patients with severe constipation, and the correlation between daily processed cheese consumption and impaction is striking. One patient consumed processed cheese slices on sandwiches every day for lunch, cheese sauce on vegetables at dinner, and cheese spread on crackers as an evening snack. Her total processed cheese intake exceeded 6 ounces daily. When she presented to the emergency department with severe abdominal pain, imaging revealed fecal loading throughout her colon and a hardened mass in her rectum that required manual extraction. Within 3 weeks of eliminating all processed cheese and replacing it with small amounts of natural cheese and plant-based alternatives, her bowel function normalized completely. The second food is white bread and products made from refined white flour, including white sandwich bread, hamburger buns, hot dog buns, most bagels, flour tortillas, and many pastries. The problem with white flour is not simply that it lacks fiber, though that is certainly part of the issue. The problem is what happens when white flour mixes with digestive fluids. Refined white flour contains primarily starch and a protein called gluten. When kneaded with water during bread making, gluten forms elastic networks that trap air, creating the soft, fluffy texture that makes white bread so appealing. But those same gluten networks do not disappear during digestion. In the stomach and small intestine, white bread breaks down into a paste-like consistency, glutinous and sticky. As this paste moves into the colon, it lacks the fibrous structure that would normally provide bulk and stimulate peristalsis. Instead, it tends to adhere to the intestinal wall, slowing transit time and creating a coating that interferes with water absorption dynamics. Multiple studies have shown that refined grain consumption correlates strongly with constipation prevalence. A research team at the University of Michigan analyzed dietary patterns and bowel function data from 9,600 participants over an 8-year period using food frequency questionnaires and validated constipation assessment tools, and they found that individuals consuming more than 4 servings of refined grains daily had a 67% higher incidence of chronic constipation compared to those consuming fewer than 2 servings daily, with the relationship showing clear dose-response characteristics. The mechanism extends beyond simple fiber deficiency. White bread has a high glycemic index, meaning it rapidly converts to glucose in the bloodstream. This glucose spike triggers insulin release, which affects not only blood sugar regulation, but also gut motility. High insulin levels are associated with decreased intestinal muscular contractions, literally slowing the movement of food through the digestive tract. Over time, a diet high in refined grains trains the gut to move more slowly, setting the stage for constipation and eventual impaction. Dr. Liana emphasizes that whole grain bread, while better than white bread, is not a perfect solution for everyone dealing with constipation. Many commercial whole grain breads still contain significant amounts of refined flour and added binding agents. The ideal replacement is genuinely whole food sources of grains like steel-cut oats, brown rice, and quinoa, prepared simply without processing that removes their natural fiber content. The third food is red meat, particularly beef, pork, and lamb consumed in quantities exceeding 3 to 4 ounces per meal, or consumed daily. The issue with red meat is multifaceted. First, red meat contains 0 fiber. Every ounce of red meat consumed represents calories and volume in the diet that could have come from fiber-containing foods, but did not. When red meat dominates a meal, as it does in the standard American dinner of a large steak or burger with minimal vegetables, the total fiber content of that meal plummets. Second, red meat is high in iron, particularly heme iron, the form most efficiently absorbed by the human body. While iron is essential for health, excess iron has a constipating effect. Iron supplements are notorious for causing constipation, and dietary iron from red meat produces the same effect when consumed in large quantities. The mechanism involves iron's interaction with the gut microbiome and its effect on intestinal secretions. Third, red meat takes longer to digest than most other proteins. It sits in the stomach and small intestine for extended periods, and by the time it reaches the colon, it has been largely broken down into components that provide little bulk for stool formation. This combination of 0 fiber, constipating minerals, and slow transit creates conditions perfect for impaction, especially when red meat is combined with other foods on this list. Studies on populations with high red meat consumption consistently show elevated rates of constipation and colorectal problems. Scientists at Harvard Medical School conducted a prospective cohort analysis involving 43,500 women followed for 16 years using biennial questionnaires and medical record verification, and their data revealed that women consuming red meat daily had a 38% increased risk of developing chronic constipation compared to those consuming red meat less than once weekly, independent of other dietary factors. Dr. Liana does not suggest that red meat must be eliminated entirely forever, but for anyone currently dealing with constipation or at risk for impaction, a complete break from red meat for at least 4 to 6 weeks allows the digestive system to reset. After that period, if red meat is reintroduced, it should be in small portions, no more than 3 to 4 ounces, no more than twice weekly, and always accompanied by large servings of high-fiber vegetables. The fourth food is bananas, particularly those that are underripe or barely ripe with significant green coloring. This inclusion surprises many people because bananas are often recommended for digestive health. The reality is more nuanced. Ripe bananas with brown spots contain soluble fiber and sugars that can help with some aspects of digestion. But underripe bananas contain high levels of resistant starch, a type of carbohydrate that resists digestion in the small intestine and passes into the colon largely intact. While resistant starch can be beneficial in small amounts, providing food for beneficial gut bacteria, in large amounts or in individuals already prone to constipation, it exacerbates the problem. Resistant starch has a binding, thickening effect on stool. It also absorbs significant amounts of water, pulling moisture away from other stool components. And underripe bananas contain tannins, compounds that have an astringent quality, further contributing to harder, drier stool. The traditional use of bananas in treating diarrhea reflects this binding capacity. What helps stop diarrhea by firming up loose stool does exactly the wrong thing when someone is already constipated. Dr. Liana has counseled numerous patients who consumed daily smoothies containing bananas, often multiple bananas, believing they were supporting their health. When they eliminated bananas for 3 weeks and replaced them with berries or other fruits higher in insoluble fiber and lower in resistant starch and tannins, their constipation improved dramatically. The fifth food is chocolate, and this specifically refers to milk chocolate and most dark chocolate products, not pure cacao. Chocolate contains several compounds that slow intestinal motility. The first is caffeine, though in relatively small amounts. The second is theobromine, a methylxanthine similar to caffeine that affects smooth muscle function in the digestive tract. The third component is fat, specifically the saturated fat from cocoa butter and added dairy fat in milk chocolate. High-fat foods generally slow gastric emptying and intestinal transit. The body requires more time to digest and absorb fats, so the digestive system naturally slows down when processing high-fat meals. Chocolate combines this high-fat content with pharmacologically active compounds that further decrease gut motility. Additionally, most commercial chocolate contains very little fiber and high amounts of sugar, displacing potential fiber sources from the diet while providing calories that contribute to overall metabolic dysfunction. Multiple clinical observations have noted the association between high chocolate consumption and constipation, particularly in children and adolescents. Dr. Liana recalls a teenager who consumed chocolate in various forms throughout every day. Chocolate cereal for breakfast, chocolate milk at school, chocolate candy bars as snacks, chocolate ice cream in the evening. His constipation was severe enough to cause fecal impaction requiring emergency department intervention. Within 2 weeks of eliminating all chocolate products, his bowel movements normalized, and he avoided recurrence by keeping chocolate as an occasional treat rather than a daily staple. The sixth food is dairy milk and products made primarily from dairy milk, including ice cream, cream-based sauces, and milk-based yogurt. The relationship between dairy consumption and constipation is complex and somewhat controversial in nutritional science, but the clinical evidence is substantial. A significant percentage of the population has some degree of lactose intolerance, meaning they lack sufficient lactase enzyme to properly digest lactose, the primary sugar in milk. When lactose is not properly digested, it can cause various symptoms. And interestingly, while lactose intolerance is famous for causing diarrhea, it can also cause or worsen constipation in many individuals. The mechanism involves how poorly digested lactose affects gut motility and microbiome composition. Additionally, dairy protein, particularly casein, forms curds in the stomach that are slow to digest and can create a paste-like consistency in the intestines similar to what white flour produces. A 1-beta-casein, the primary protein in most cows' milk, has been specifically implicated in digestive distress and altered bowel function. Research conducted at the Hospital for Sick Children in Toronto examined 65 children with chronic constipation using a randomized controlled crossover design where participants eliminated cow's milk for a defined period and then reintroduced it. And results showed that 68% of the children experienced significant improvement in bowel function during the milk-free period, with symptoms returning when cow's milk was reintroduced, suggesting a direct causal relationship in a substantial subset of individuals with constipation.